We're going to go ahead and get started because we have a lot of great material to get through today. For those of you I haven't met before, my name is Nancy Butcher and I'm the co-director of Impact. Today we are really delighted to have Dr. Melody Barwick with us from the Child Health Evaluative Sciences program at the Hospital for Sick Children. She is also part of the Sick Kids Center for Global Child Health, and she's going to be speaking with us about designing effectiveness, implementation, hybrid trials, and child health research. So in terms of process, Melanie will speak for about 45 minutes, and then we will have an open Q&A session until the top of the hour. So please hold your questions until the end of the 45-minute period. And after that, we will, as usual, have a closed discussion period between Dr. Barwick and the Impact Fellows and the Trial Enrichment Group learners. So if you're a member of those groups, please stay on this Zoom link at the end of the webinar. All right, let's go ahead and get started. Over to you, Dr. Barwick.
Thanks so much, Nancy and Chelsea, for organizing. Can you hear me okay? Perfect. Okay. So I'm really pleased to be able to do this webinar and meet with the Impact Fellows during this time. When Nancy first reached out to invite me to do this webinar, I had to give her a big disclaimer that I am not a clinical trialist, but I do many and most of the time effectiveness hybrid trials of this nature. And so this is based on my 30 years of research background and my specialty in implementation science. So the other thing I wanted to sort of mention right off the bat is that there's a little bit of information that I'll be providing just to give you a sense of the science of implementation and where we're at and how we approach it. Because every time you're doing a trial and you're studying the implementation of an innovation, you're doing that in a real world setting or several real world settings. And you need to understand how implementation works. It isn't just about knowing your specialty area, your substantive content area, whether that's, Crohn's or pain or mental health. It's also about understanding the science of implementation and how that science of implementation is applied in real world settings. So we're going to talk a little bit about implementation core elements and then move into talking about hybrid designs. So your learning objectives, your task over the next hour or so, an hour and a half, is to understand the challenges as I present them in a very light touch kind of way, just given the amount of time we have, the challenges of implementing evidence in practice settings. Identifying the 5 implementation core components as I'll lay them out. We really need to find a way to disseminate and communicate implementation science in ways that are not complex, that are not overly academic, that are simplified so that the individuals in practice settings can understand them and apply them. So distilling it into core components is really important. And then we'll talk about 3 types of hybrid designs and go through some examples of how they have been applied in pediatric settings. And I'm also going to introduce you to the standards for reporting implementation, the STARI guidelines that you can find in the Equator Network as an important tool to use as you are developing your innovations, developing your clinical trial designs, and executing them and reporting on them. So here's just a few things I would like to share and have you think about around implementation process. Oftentimes when we communicate about the implementation of an innovation, when we disseminate information about our innovations, we do a fairly good job of disseminating to various audiences, hopefully in ways that are preferred formats and understandable to a range of knowledge users. But one of the things we aren't so good at is describing what I call as what's in the box, meaning not just information about what the innovation is and where it's been used and what the evidence is on its proven effectiveness. While that is all important, we often don't tell people what's in the box. What are the core components of the innovation? What do people have to implement and have in place in their organizations in order to deliver it? And it's one of the things that is critically important as you're thinking about your innovation and as you think about how you're going to study it in a real world setting. Because fundamentally, in a clinical trial, I would say some of the time, maybe not most of the time, but probably a good portion of the time, your mini implementation in that clinical trial is going to leave something behind. Fundamentally, what you're hoping to do is to try out this innovation in a setting, but have that setting continue to deliver the innovation. Otherwise, and there might be reasons not to do that. Most of the time you're doing that. And so you want to be able to communicate to your organizations what they actually have to put in place. What are the must-haves, non-negotiables? So do they have to do a type of assessment? Do they have to integrate something digital? Do they have to have specific types of equipment and so on? So it's an important place to start thinking about if you are working as an interventionist who is also interested in their interventions being adopted. So I think of evidence-based innovation core components as as I mentioned, the things that have to be done, the essential functions, the essential principles, and they're also the things that define one program from a similar type of program that purports to do the same thing. So these are things that have to be put in place by the implementing organization. And if they're not in place, then the organization is not delivering the innovation you think they're delivering. They're not delivering with fidelity. And one of the things to be mindful of as researchers is that as you're doing this research, you will have research procedures, research methods, a list of things that fall in that bucket that you want to be mindful of, that you are applying and executing and measuring. But over on the other side, you also have the innovation that you're implementing, the core components of the innovation. And so it's important not to conflate the two. And it's really hard for researchers to not do that. So hopefully that'll become a bit clearer as I talk. One of the things we do and we've embedded in the tools we use to support implementation and practice is an exercise called the practice profile. It's a templated tool that is a place where you can identify the core components of your innovation and where the implementing organization can discuss and describe how is that going to be done here? How are we going to put that in place? What do we need to do to get there? Who's going to do it? And who's engaged in providing that core component? And how are we going to know it was done with fidelity? So having that laid out, it's sort of a map or a recipe for how the implementing organization is going to do the work of implementing your innovation. And while you're studying it, this is also happening in parallel. And so thinking clearly about what those core components are and providing tools to the implementing organizations, what you would call the study sites, is a sort of a parallel process and activity that's happening in your trial. Just as a caveat, one of the things I do in my own research of this nature is I try, especially when I'm working with the quote unquote study sites, is to not talk about the project as a study, because oftentimes the project sites, which are organizations, are adopting an actual innovation. You just happen to be studying it while that's happening. So I use their language and not research language, which helps the organizations that you're engaged with become more independent, more responsible, have greater autonomy over the decision-making that needs to happen in terms of how they're going to adopt that innovation. So the practice profile gives them the opportunity to articulate how they're going to address each of the core components. And it looks sort of like this. So this is an example of a practice profile for an innovation that we're studying now. It is an integrated care pathway developed at the Center for Addiction and Mental Health in Toronto called Caribou. And it is a pathway that is being deployed in community-based child and youth mental health organizations. And so the core components, you see 7 things listed on the left of the profile here. They describe what those organizations need to have functionally in place in order to say, hey, we're delivering Caribou as a care pathway for youth with depression. They need to have do a specific type of eligibility assessment for the program. They need to be able to provide a psychoeducation module for the youth and their caregiver, if their caregiver is involved. They need to be able to do measurement-based care digitally, so that's an issue. They need to be able to have their clinicians trained in providing 2 types of treatment, cognitive behavior therapy and brief psychotherapy. There's caregiver support. Actually, I'm missing one. Yeah, and discharge planning, but there's also medication management. So the organizations need to think through, how are we going to do medication management when we don't have a child psychiatrist, for instance? How is that going to work here? How are we going to make that work in our organization? Who's involved in delivering that, and how are we going to know it's happening with fidelity and competence? And so the implementing organizations that you will be working with as your quote unquote study sites could use this type of tool to really understand how to make that innovation come alive in their organization. One of the ways I talk about implementation to people who are not implementation scientists is to usually with an analogy. And an analogy that works everywhere in the world. I have tried this in African countries and elsewhere, and they get it. This is to help you kind of understand all the moving parts of implementation. And I call it the implementation kitchen analogy. Some of you will have seen this if you've taken implementation training with us at Sick Kids. But I use this analogy because everybody has the experience of cooking. You've cooked something, whether you're a good cook or not a good cook, it doesn't matter. And cooking happens in a kitchen, so there's an environment, but my kitchen could be very different from your kitchen. Your kitchen could be a campfire or a burner in a camper, or a perfectly outlaid kitchen in a house, or it could be an industrial kitchen. So that's context, right? That's your situation of what you have available. You have a structure in that kitchen that enables you to cook. You have a cook, at least one person is making this. You follow a recipe, whether that's in your head or something you're making for the first time, and it's, you're actually following a path or a recipe. You think about the ingredients, you read the directions and follow the directions, but your surrounding conditions as you're doing this task matter. Making pizza dough on a stinking hot day, that's a consideration. Cooking dinner with little ones around you who are starving and annoying you while you're trying to get dinner on the table, that's a surrounding condition. Cooking in a kitchen where you've just moved in 24 hours ago and you can't find what you need because it's all boxed up. Those kinds of things are the things we consider as specific to the organizations that are implementing. We use strategies, we think about food chemistry, we make substitutions sometimes, and we think about the people involved and how we're going to evaluate our cooking. Are our kids going to eat it? Is it a costly recipe to make? What's the nutritive value, and so on? And somehow, I don't think this has, yeah, sorry, I'm just going to need to pop out of this for a moment because I can't remove this box, but I will do that. Come back to you. Forgive me, a little technological glitch. We're going here, share. Okay. Nancy, I can see you, so thumbs up, we're back to the slides. Okay, so the analogy in implementation is that you're working with a setting, right? These are your, what do you call them, your study sites or your implementing organizations. They'll have some similarities, likely based on what you're studying, but they're all different. So they may provide the same kinds of services, but they do it differently, perhaps, or with different types of workforce. They have their own organizational conditions and ways of doing things. So think about resources, people, workflow, structure, environment, physical structure, clinical procedures, all of that sort of business. The cooks are the implementation team. And one of the things that researchers need to be mindful of as they do clinical trials and implement things in real world settings is that the researcher is not the implementation team. They can be on the implementation team, but the implementation team sits in the organization. It's individuals who have management skills, implementation knowledge, technological skills that are needed, and so on. They're the ones doing the work of the implementation. You're oftentimes, as a researcher and maybe an interventionist, you're the developer, you're the purveyor, you can offer support, but you can't really make the decisions that they need to be making. The innovation is your recipe. That's what you're making, and the ingredients are the core components. And the core components are those essential parts of the ingredients. If I give 120 of you a muffin recipe, you're all going to make it. You're all going to have different conditions. But at the end of the day, if you don't put the core components of the recipe, ingredients in there, you're not going to end up with a muffin. So we want to end up with the same innovation in every instance, in every setting, but how that actually comes about might be a bit different. So they follow a process. They think about their enablers and their barriers along the way so they can adapt to those situations. They use implementation strategies to either amplify their enablers or to mitigate or avoid the barriers along their process. They make adaptations, but when we make adaptations to innovations, we need to mostly think about adaptations to the who and the how of the implementation, and not so much an adaptation to the core elements of the innovation itself, because then we're going rogue and we want people to deliver innovations with fidelity. We think about who's delivering the innovation, who's receiving it, important parts of the equitable implementation process, and we have ways of evaluating our implementation. I'll talk more about that evaluation piece as I talk about the process. So when you feel you're lost in the sort of multitude of things to know about implementation science alongside your substantive content science, this might help you feel a little bit more grounded in what that process entails and all the moving bits that are involved. For some reason, my computer is not moving forward. There we go. So taking that long list of here are all the things you need to think about, we have an approach that simplifies all those moving bits into 5 core elements of implementation. So by that, I'm saying for whatever you're implementing, your process of implementation is something you need to think about, for one. And secondly, you're going to need to talk about 5 core elements of your implementation approach: the team, the implementation team, the cooks, the process of implementation. Oftentimes when you read clinical trials that have implemented something, they don't tell you how they implemented it. They may tell you that they train people, but they don't tell you how they went about the implementation process. And that's a really important piece to be conveying and to be thinking through as you design your study. The factors are the barriers and the enablers, and we're continuously identifying them and addressing them through the process. The strategies are the things that are helping us address those. And then outcomes. And by outcomes here, I mean implementation outcomes, not clinical outcomes. So when you're implementing in your clinical trial, you have the evidence behind the innovation in whatever area you work in health or outside of health, and you have the evidence for implementation science. Clearly, we're implementing that innovation because we want to have an impact on health and well-being, and so we're going to measure, are we having an impact on health and well-being? But we also really need to know, was our implementation of that innovation successful? And so we call those implementation outcomes, and they're important to measure alongside your clinical outcomes or your service level outcomes or the things that are more attuned to your innovation. When we talk about the team, we're talking about, as I mentioned, people who are in the implementing organizations. When we're talking about implementation process, we're talking about a staged or phased approach to the implementation approach. Now, what you will often see in papers is an implementation approach that is only strategy driven. We're going to pick some implementation strategies like training, a needs assessment, audit and feedback, and put those in place. But what that doesn't do is consider the surroundings, the organizational conditions of your implementation settings. And so process is really important. It's really what the other aspects anchor onto. And organizations that are implementing innovations in your studies need to be sure that what they're implementing is a good fit. So they have to have their own internal process of examining fit, feasibility. Do they have the capacity to implement it? Typically, what we do when we select sites for these kinds of studies is we call up our buddies and we say, you know, we're doing this study. Do you have the right kind of sample? Do you want to do it? And they have their own motivations for wanting to do it. Not necessarily the case that the organization has the capacity to deliver that innovation. They may have the client population or the patient population, but they may have other holes in their organizational functions that means they'll have great difficulty with some of the other core components. You want to engage stakeholders, and all of that information backs the organization's decision to adopt something. And when you do the practice profile for an innovation within an organization, you can identify where do we have to do some work. In the care pathway that we're implementing in Ontario, one of the core components is measurement-based care, but it requires a digital system. Lo and behold, most child and youth mental health organizations in Ontario don't have digital systems for measurement-based care. So they're all going to have to find a way to get there if they want to implement and deliver this care pathway. So you start to see how it creates the tasks and the activities that organizations will need to address in order to deliver your innovation. You might need to train staff. You might need to make some organizational changes in these organizations. This is all the work of the people in your partner organizations, your sites, as we call them. And then they can launch the new service or the new innovation, track, monitor, evaluate fidelity for implementation. Is it actually being delivered the way it's supposed to be delivered? And also track the clinical outcomes that you want to track. And then work towards what they will do with this innovation after you, as a researcher, fade away. You've gotten what you need, you're going to publish and disseminate now, and they're left holding the bag for this innovation. Have they put enough in place to be able to sustain it over time? And this is something that you should be thinking about as you design your study. There are a lot of factors that can get in the way. These are the barriers and the enablers. I think the list is up to over 30 now. There are ways of categorizing them, as you see on the slide. Some barriers and facilitators are associated with the implementation process. Others are associated with the innovation or the inner setting, meaning the organization, the outer setting, meaning the health system, let's say, or are related to the individuals involved in this process. We use strategies to address some of those barriers or to amplify the facilitators. So planning strategies, educational strategies, and so on. That's a whole other body of work in implementation science that needs to be more accessible to people. So these are examples of implementation strategies, evaluating strategies, adapting and tailoring context, training and educating people. And how would you engage consumers? What if you need to change your infrastructure, and so on. And then implementation outcomes, as I mentioned, tell you if the implementation process was effective. Why would you want to know that? Even if that's maybe not your central question? Because if you are looking at your intervention data at the end of your trial, and let's say you have two arms in your trial and you're not seeing the evidence go in the way that you would have liked to have seen it go, you want to be able to explain whether that's a problem with the intervention or a problem with its implementation. And if you haven't looked at implementation outcomes, you're not going to know. There are 8 widely used implementation outcomes. You see them listed here. The first 5, so the top row plus feasibility on the second row, are explored early on in the implementation process while you're making a decision about what to implement. Acceptability of the innovation, intention to adopt, how appropriate it is, whether it's cost prohibitive or something you can actually afford, and how feasible it is. And you want to know that in your partner sites before you get going, before you firm up that they're actually going to be a partner site. For the care pathway study, we actually didn't list our partner sites in our proposal. We got funded anyway. And the reason we did that is that we wanted to make sure that the organizations involved in our trial were organizations that had the capacity to implement the pathway. And the way we recruited our organizations is we put out a statement of interest. We tweeted, this is what we're going to be providing. Here's a bit of information. If you're interested in learning more, come to our webinar. If they were interested after the webinar, we met with them separately. We talked about the core components, what the research obligations would be, and we really gave them the information they needed to know about whether they wanted to participate in our study. It's a very different way to go about it, but I think it's very effective because you don't end up having sites that are going to abort the process because all of a sudden they run into difficulties and see that they can't actually deliver. You start to look at fidelity and penetration and sustainability later on in your implementation process. So that's really a quick overview of process of implementation. The things I would stress there are thinking about the organizational context and capacities of your study sites or participating organizations and individuals as you invite them to participate in your study, as you think about as you develop your innovation, who's going to use this innovation? Where is it going to be used? How will it be used? What kind of capacity for taking this on do those types of organizations have right now? This is all going to inform your development and also the study of the innovation in a real setting. Thinking about implementation science questions that you can be asking, an implementation science question is really defined as something that focuses on implementation science. You might also be interested, and particularly in hybrid types of studies, on the clinical science that you're implementing. But these are questions on the implementation side about the implementation process and how does that work? Can we actually implement the integrated care pathway for depression in community mental health settings? Is that going to work? Because it was developed at CAMH, at the Center for Addiction and Mental Health, which is a well-resourced, large research academic health center. Well, Community Mental Health Center in Temiskaming is not a good comparable, but they are serving the population this intervention is intended for. Are they going to be able to implement those core components? And we're paying attention to context, right, where the implementation occurs, because that's going to shape how effective your intervention is. So the types of questions we might ask are about maybe improving distribution or use of the evidence, what's going to work best for that, what are the best methods for incorporating new discoveries in clinical care? What factors might implement the implementation of your intervention in particular settings? So we see a lot of research papers on barriers and facilitators of implementing X intervention in these particular types of settings. How do we address those factors and modify them? And also, a big segment of research on de-implementing ineffective practices. So how do we get people to shift from something they've done for a really long time and it's completely ingrained in their day-to-day process to drop that and take up new practices? And what are the best methods that we can get people to do that? So this just gives you an example of some of the core questions that these hybrid studies are asking. Some of them have to do with what are the challenges of implementing? So how can we implement multiple times across a whole sector or system of care, which is the scale up sort of question. How can we ensure that organizations that implement new innovations sustain those innovations beyond the initial efforts? How can we make sure that we don't encounter or create inequities or health adversities in the implementation process? And how do we consider equity throughout the whole implementation and delivery of new innovations? And also opportunities to, go outside your lab, to go outside much more controlled settings and say, can we do pragmatic trials out there in the real world and see how that works out? There might be questions relating to different objectives. What are the possible factors related to how well this goes? Describing context issues and describing health outcomes that are due to the implementation of the intervention and how that shifts. Explaining how interventions lead to effects, predicting what the future course of this implementation will have on the organization or on the recipients, and thinking about how to make implementation efforts for your innovation that you're interested in be accessible, feasible, and useful to these settings. We use implementation theories, models, and frameworks in the background to inform our methods. So, why would you think about familiarizing yourself with dissemination and implementation theories? Well, it guides your planning. It informs your evaluation. It helps you understand the factors that are critical to the implementation being successful. And, it gives us a bit of a structure around common language for people working in different areas of health and in different disciplines. So as you're working to design your trial, you're thinking about research methods. So, which research methods are you gonna draw from depending on what you're doing? This is not an exhaustive list, but it gives you 14 different types of research methods typically used in these kinds of hybrid studies and in other implementation science designs. You want to be thinking about your research design. So, the 7 Ps of how's that implementation actually going to happen? What are the procedures? What are the programs? What are the products, etc. The other thing that is a bit of a shift for researchers to think about is most of the time we're doing trials with attention to internal validity, but implementation science is messy research. Oftentimes it's pragmatic in nature, and here we're largely attending to external validity. So we want things to work in multiple types of settings where there are a lot of moving parts, but we still want the intervention to remain pure, which is to say those core components are implemented and people are delivering with fidelity. So if you like things to be cut and dried and super neat and tidy in your research methods, implementation science in practice might not be for you. So this is a common sort of research pathway of how we transition from efficacy studies to effectiveness studies to this box of activities in the upper right that are really the exploration of implementation. So how do we adapt? How do we prepare? What's feasible? Piloting interventions in small ways before we get to larger scale ups, actually studying issues around implementation and sustainability. And probably since this was published in 2017, I would add equitability and considerations to diversity, equity, and inclusion in this pipeline and the implementation boxes. Probably also sustainability studies. So lots of different designs apply in implementation science research, within site designs, between site designs, factorial designs, etc. The website that I have listed here at the bottom is University of Washington's implementation science focus. It's a fantastic website. It's where I go. It's informed a lot of these slides. And I highly recommend if you're delving into implementation science for the first time, to go and check out what they have in terms of resource. They have links to lots of papers and lots of other resources. So it's a really good core resource to have in your set of tools. So as you develop your intervention and start to think about how are you going to implement it, and developing an implementation effectiveness type of study, you want to sort of locate yourself on what they call the subway line of translational research. This comes from Megan Lane Fall and Jeff Curran and Renad Betas all in the United States, where much of the implementation science occurs. So thinking about the intervention or the practice that you have as something you want to disseminate, whether it has shown efficacy, yes or no, kind of leads you in a different path. If it has the intervention of practice shown effectiveness, no, kind of, and yes. And the hybrid effectiveness implementation trials sort of can fit in the no and yes section, partial and yes. And you can use different kinds of designs to do them. Before I get into the 3 types of hybrid designs, I want to just quickly mention reporting standards, and in particular, the STARI, as I mentioned. You can find it on the Equator Network. And what's useful about reporting guidelines, obviously, is not just at the end of your research, but it really helps inform your methods. And this is the checklist for the STARI. And what you'll see is primarily 2 columns: your implementation strategy and information about your intervention. Now, you're going to feel, if implementation science research is new for you, way more comfortable on the right side of this table, where you can describe things to do with your research methods and your intervention. You can provide a rationale for why you're using this intervention. You list out your aims and objectives. You provide a design and the context, how you've selected sites, a description of that, subgroups. You will describe your methods. So what outcomes clinically are you interested in, your process evaluation, your sample size, all, the drill. This is the typical things that we report on in studies. But you also need to do that for the implementation strategy or approach. That is to say, what's the rationale for choosing this implementation strategy? Remember, it's its own science area. How can you describe your implementation process and approach? You'll also want to be able to be mindful of the methods of implementation, not just the methods of the intervention delivery. And you want to be able to capture information about implementation outcomes, whichever ones are of interest to you. You might be capturing information about the economics of implementing the innovation, fidelity to the innovation, and then the implications for policy, practice, and research. So you have 2 parallel streams of planning, thinking through methodology, the methodology of delivering the intervention and the methodology of implementing it. And then that follows through to your what data you're going to capture and how you're going to report it. So hybrid effectiveness designs are really a blend of those 2 things, a blend of your efficacy and effectiveness research for the intervention itself, mapped, integrated with questions about implementation. The 3 types of effectiveness hybrid designs pertain to how much emphasis and attention you're given to intervention and to the implementation side of things. And the reason we do this is because essentially it is more pragmatic. It speeds up your process. You don't want to spend 10 years testing out effectiveness of an intervention, only then to start thinking about who's going to use it, what kinds of environments or organizations will use it, how usable and implementable is it. You want to start asking those questions a lot earlier. So you make gains in intervention uptake because you figure things out earlier in terms of what the problematic areas are going to be for implementation, which implementation strategies are going to be effective, and what's most useful for the research side and for the clinical delivery side. So it exists in this little pocket. That's where hybrid studies are. The first hybrid type is really where you're focused on testing a clinical intervention that's not well established. And you're gathering information on its delivery during the effectiveness trial. So it's a lot of emphasis on clinical outcomes and a little bit of interest burgeoning about how implementable is this going to be? It's more process focused. You're not necessarily thinking about implementation outcomes. You're just testing the implementation waters. When you get to a hybrid type 2, they're both equivalent. You have clinical questions. It's now a more established clinical intervention with more data behind it, but you're also asking some important implementation questions. It's that direct blend of both of those worlds. And in a type 3, you're testing the implementation approach, and you might still be typically you're still capturing information about what the clinical outcomes are, just not to prove that the intervention is effective, but only to capture that it hasn't been adversely impacted by your implementation. So the work is done about, yes, this is a well-established proven intervention, but now we're focusing on implementation strategy and what works for this intervention in different types of settings. So hybrid type 1, Jeff Curran, who first proposed the hybrid design, talks about the thing. The thing is your intervention or your innovation. So you're testing the thing and you're starting to explore implementation related factors. So it's sort of really mostly an intervention effectiveness study, and then there's this little bit tacked on. So how might the thing need to be adapted going forward as you're still establishing it and developing it and building evidence for it? What's needed to support people and places to do the thing in the real world? And so you're still, you have limited evidence on the effectiveness of your intervention, but you're really starting to ask important questions about its implementability. I've given you here 2 examples of type 1 hybrid studies. I'm going to go quickly so that we can at least point out some of the problems and the advantages of one of these. I'm going to pick it apart, essentially. And we're going to talk about this one, which is on the left here, the hybrid type 1 implementation trial on International Guide for Monitoring Child Development, la-di-da-di-da. It's a protocol paper. And this was just their abstract. They're addressing young children who don't reach their developmental potential. And there's an international guide for monitoring child development, which is its own package. And they're looking at the implementability of this package, but mostly they're looking at the effectiveness of this, this early guide. And so, what I've shared with Nancy and Chelsea are these papers that I'm picking apart, with all deference and respect to the authors. So you can think about this offside once this webinar is over, and go through it yourselves, maybe with the STARI checklist, and read the paper and try and see whether they align. So they did a cluster randomized trial. It's a crossover to the intervention. That's the design. They're using digital mobile device interface. They're looking at clinical outcomes. They're also looking at implementation outcomes, and they're also interested in identifying barriers and enablers. If it weren't for the fact that this intervention isn't more ahead of the game in terms of proven effectiveness, this might be a type 2 in the sorts of things that they're considering. But I think because it's early days for the intervention, they've made it a type 1. So they got right measuring implementation outcomes, measuring barriers and facilitators, and they talk about that. But there's no mention of how they're going to implement, and there's no description of the implementing organizations. So, I know you can't scan and read this super quickly. Their eligibility criteria is specific to the patients. There's nothing about which types of organizations are actually eligible to be a study site. How was that determined? And do they have the capacity to implement and deliver this intervention? So that's important information that is missing from their approach and from their reporting. There's no mention of implementation process, other than what's behind some of the measures that they're using. There's no description of the implementing organizations or the study sites. That's important because it's important context. As I mentioned, their eligibility criteria are missing, and they've not stated whether the intention of everybody engaged here is that the intervention will continue to be delivered when the study's over, or whether it's we're in, we do the work, we're out, and the organizations are no further ahead. In a hybrid type 2, it's that equal balance of testing the thing and doing the thing. So testing and implementing. You're really spending equal amounts of attention, method, procedures, and everything in both of those camps. And here again, I've given you 2 examples of hybrid type 2 studies. One's a pilot study protocol. Well, they're both study protocols, actually. But looking at the one on the left by Long et al., we can again start to pick out some strengths and weaknesses of their approach. So they're focused on online screening of GPs for neurodevelopmental follow-up. It's a single center randomized effectiveness implementation hybrid type 2 design. It's a pilot. They describe their population and so on. So what did they get right? They use a guide. They use theories, models, and frameworks. So the Consolidated Framework for Implementation Research, which is a determinant framework that helps to identify barriers and enablers. They use Proctor's Implementation Outcome Taxonomy, which defines 8 types of implementation outcomes. They are going to study the mechanisms of change. They've identified some of the core components of the innovation. Often that's missing. So you can see on the right where they describe the intervention, they say, if you were to look in the box of what the intervention is, this is what organizations would have to deliver on and put in place. No detail was provided about organizational recruitment again, right? We're just kind of picking sites as though they were anybody with access to that patient population. That is not the only consideration when you are also studying implementation. Just saying, it's a big miss, and it occurs a lot. In a type 3, I know I'm a bit over time, Nancy, but I'm going to roll it up here. We are working with established interventions that have a lot of proven effectiveness, and we're largely focused on evaluating implementation approaches and strategies. And so the emphasis is on implementation. There are 2 study protocols here, and I've picked the one on the right, Renée Bedas. And I will preface this by saying Renat is an implementation scientist. So I'm looking for her paper to have a lot of things right, which it did. So here they are looking at implementing an adolescent and child suicide prevention study. It's a hybrid type 3. This is about firearm safety. And so they describe that in their abstract, what they got right. They describe the core components of the program on the left. So you need to be able to do screening. You need to have counseling available. You need to, part of the core component of this program is that the proponents need to have safe storage tools, etc. So they describe when you apply this innovation, here are the things that have to be done. Yeah, so they're using a whole bunch of theories, models, and frameworks. They describe that as well in their paper. In their methods, they talk about how this adheres to the STAR-E guidelines. They talk about what kind of design they're using, and they talk about the implementation framework, the targets, and the mechanisms. So this is information about here's how we're going to do the implementation process, which is often missing in other studies. When you think about which research design you should use, there's sort of a bit of information here to help you pick through. And we don't have time to go through it in detail, but as you know, you will have the slides and you can read through this. Much of this is courtesy from Jeff Curran himself. You know, how much evidence is behind it, behind the intervention will help you largely decide which one you should do. How much do you already know about implementation and how implementable it is? Are you ready to evaluate in a real world strategy or not yet? And also remember, lastly, that you don't need to do a hybrid study. You can be interested in implementation, you can be interested in effectiveness of the intervention separately. It might be too early to do a hybrid study. Maybe your intervention needs more, it's really hard to implement something while you're building it. And we've run into those kinds of problems in some of our own work. Maybe you don't even need to look at intervention effectiveness. It's such a well-established intervention that you're only focused on implementation. That's not a hybrid study, but it's a really good study. Maybe there are questions about implementation that you are interested in separately. So that's what I have for you as sort of a whirlwind 50-minute, sorry about that, overview of what you need to be thinking about as you develop your interventions and as you go to test them in real world settings, and what sorts of hybrid designs may be appropriate for the work that you're doing. Some of you will be early days in your intervention development. Others will be working with interventions that are more firmly established, and you may have questions about how implementable and useful they are in different contexts. So hybrid studies may be appropriate. So that's what I have. We have time now for discussion. I'll turn it back to Nancy.
Thank you so much for that excellent introduction to hybrid effectiveness and implementation trials, Dr. Barwick, and the pediatric examples were also very illuminating. So we have a few questions coming in through the chat. So please go ahead, folks, and put your questions in the chat. You can also put your hand up and unmute and ask directly if you prefer. Can you see the chat, Melanie? I can read them.
Yep,
okay.
Yep. The first question, can you please define what you mean by measuring patient engagement in implementation science? How do we measure this? Any studies done to measure this? So it's a really interesting question, because I think as health scientists of all kinds, we're really encouraged to consider the patient and the patient perspective. Implementation is a little step back from that, in the sense that when we are working in practice as implementation practitioners or consultants, or when we are working in the science and the research of implementation, we're not engaged with the patients. That's not to say we can't be, but we're not engaged with the patients because we're working at the level of the organization. So when I think of who I work with mostly, I work with organizations and with staff members throughout the organization who get tasked with implementing something. They need to consider the patient, and we need to consider the patient in the process in several places through the implementation process. So beginning with, what innovation are we selecting to implement? Who's it for? Is it going to be accessible to everybody we provide service to? Being mindful of what their needs are. You could decide to address that by inviting a consumer or a person with lived experience and living experience to join your implementation team to add that perspective, in much the same way you would invite them to join a research team to ensure you're asking relevant questions, you're interpreting your data properly, and with a view to many different voices and perspectives. So how patient engagement happens specifically in implementation is not something I have seen published. That's not to say it's not there. Interesting question. And I think not central at this moment from what I'm seeing in sort of the pockets of implementation research that are happening now. People are asking questions about equitable implementation, sustainability of implementation, mechanisms, process, behavior change, de-implementation. Fewer questions about who's engaged in that work from a research question perspective. So hopefully that answers your question. Oh, tough question, Rosman. So the next question is, how do hybrid designs apply to de-implementation of an intervention? Nicola, I see you're on this. Do you have anything to add? Nicola McCleary, who's working in that area. A hybrid design for de-implementation.
One thought that comes to my mind, if you don't mind me jumping in,
Yeah,
Dylan,
jump in, save me.
just hi everyone. I'm Nicola. I'm another implementation scientist here at SickKids. It's just thinking about in terms of your outcome measurement. So in terms of thinking about
Right.
clinical outcomes, one thing that's really important from a de-implementation perspective is making sure that there are, assessing whether there are sort of adverse consequences that come from removing an item of care. So I think in terms of regardless of the level of hybrid design that you would choose, thinking about those potential adverse clinical outcomes as well as your implementation outcomes would be important. So that's just one thought.
And I suppose you could evaluate strategies for de-implementing something, which is, outcomes of that de-implementation approach. There isn't, I mean, I don't think there's as much research on de-implementation as there is on implementation. But most of the time when you're implementing, you have to de-implement something to implement something else. So, it's hard to find that, when have we stopped, or when do we stop de-implementing to implement? It's an interesting question. And I mean, I think it targets a whole bunch of options of things to explore. So I'm going to be looking to you, Rosman, to do that research. Next question. Oh, thanks, Sylvie. Well, okay. So it's up to you guys to open your mics and ask me questions because there are no other questions.
I have a very quick question that I was going to wait until we could discuss with the fellows, but maybe I'll ask it now because in my trials, I would consider myself not ready for implementation. But how do I know when I am ready for maybe a more hybrid design? Are there things that I could be collecting now that might make that process easier in my next trial?
I think you want to be thinking about, and maybe just sitting down, having a conversation with your colleagues about, first of all, you could definitely be thinking about what are the core components of our innovation, which is not what we researchers are trained to do, and it's essential for implementation, right? My core component analogy is IKEA, which I didn't include here in my slides because I'm already over time. I had to de-implement my slide deck so that I wouldn't. But, when you go to IKEA signposts the evidence behind their products, right? They show you they've punched the bejesus out of this particular chair and it's still worthy 30 years later. So they think about that. They think about their product. If we think about interventions as a product, they think about, they signpost where to find it. They disseminate well. Yeah, you have to haul the thing home yourself. But when you get it home, you have a flat box with pieces, but they give you instructions on how to put it together. And they give you the bits and the Allen key and all of those sorts of things. So you're able to put it together. It might take you 12 hours, but you're able to put it together. We do most of those things, but we don't give people instructions. And so for you, I would say, Lauren, think through the core components, do that first column of a practice profile. What are the core things that an organization would have to have in place, non-negotiable, in order to deliver X, right? So that when you disseminate information about your study or you're purveying, now your intervention is, is ready to go public and you want people to use it, you include that in your dissemination materials, not just here it is, here's what it does, here how effective it is, here's how you put it together, right? And this is a start, and here are some tools like our tools or, maybe other tools to help you follow a process to do that. So that's one thing you can do. The other thing you can do is start to think about really think about and talk to individuals in community settings or whatever kinds of settings this is for, about what they do now, what would be a relative advantage for them to change what they do from something, this was kind of a de-implementation question, but in a different light. If you were going to adopt something new, like what we're cooking, what would it take to do that? What would it take to convince you? What would be a relative advantage? Is there attention for change for this new innovation? That'll be informative for you. So that could be a type 1 hybrid design where you're starting to explore the appetite for the innovation in the settings in which you're going to implement it, what they perceive might be the barriers and facilitators to taking this on. You know, and early on, that can tell you whether you're on the right track or the wrong track,
Yeah.
right?
Kind of thinking we should all be doing a little bit of this, even if
Yes.
we're in early phase research, right?
Yeah, yeah. You know, I mean, clearly in really early trials for interventions, we're really trying to understand what the problem is, and then we're coming up with a solution or an intervention. But the minute you have a handle on what that intervention might be, you need to look at where it's going to be used, with whom, who's around, and what their capacities are. So, you know, to try and promote an intervention that, like the care pathway I mentioned, that requires digital measurement-based care in a sector that doesn't have digital measurement-based care capacity, doesn't mean it's not surmountable. You know, we're finding ways to build that capacity, which is actually an unintended positive consequence of the work that's ongoing. Because they will need digital measurement-based care for other interventions. It's a core element of many interventions these days, particularly in mental health. So it doesn't mean don't do it. It just means be mindful of where your challenges are going to be so that you can address them early on.
That's great. Thank you.
Thank you. It's a great answer. It's like we should all be thinking about designing our interventions with implementation in mind, right? For ultimate eventual uptake. So thank you for planting that seed. We will now close this portion of the webinar. So thank you everyone for attending, and thank you, Dr. Barwick, for a great session. If you are an Impact Fellow or an Enrich Impact learner, please stay on the Zoom link, and we will have our closed discussion with Dr. Barwick in just a moment. Thanks.